Thank you very much, Dr. Lopato. And he will be back a little bit later this morning to continue his talk. And we are excited now to introduce our next speaker, who is actually one of our program faculty members. Daniel Sopp will be speaking with us about pain among patients with sickle cell disease. Daniel is a PhD candidate in biomedical engineering who serves as a senior clinical research analyst for the adult sickle cell program here at VCU. He uses his engineering training to improve analytical and systematic processes for the sickle cell disease program, and we're grateful to have Daniel with us today.
Good morning, everyone. My name is Daniel. Thank you, Shirley, for introducing me. Today we'll talk about pain in sickle cell disease. But before we do that, we have a few polling questions for you. You should be able to see on your screen a poll everywhere option. If you could please answer to the best of your ability the question that you see using the software. We'll give it a minute so everyone can put in their answers. Okay. For this first question, it seems as though in the chat, I see the majority of everyone is answering D. That is the correct answer. Nice. All right, we'll move on to the next question. Which of the following statement is true or false about the cumulative impact of sickle cell disease? We give it a minute. Okay, so far 50-50, 60-30, 70-30. It seems as though the majority of the people have chosen answer A, which is actually not correct. The correct answer is C, but we'll talk about it in the presentation today. And then we have one more question. The last question, vaso-occlusion leads or contributes to which of the following? All right. Everyone has chosen the correct answer. Okay, so the goals for our talk today are to help people be familiar with pain at home, pain in the emergency room, and pain in the hospital. And hopefully after our presentation, you're also able to better understand opioids and their analgesic use. And lastly, we'll use these findings to help you better understand or debunk commonly held myths about pain and sickle cell disease. So for a little bit of a background, pain is the main symptom of sickle cell disease. It's essentially the hallmark of sickle cell disease. Pain can affect every part of the body for patients that have sickle cell disease, and it never quite exactly goes away. And what's really fascinating about pain in sickle cell disease is that it's different for every single patient. And that's why when patients report their pain, they tend not to ever really be believed because there's no objective way of quantifying that pain experience. So often we hear clinicians and physicians refer to pain as being a personal experience because there's no way for them to know exactly to what level any one person is ever hurting. So we can see pain, as we talked about, is the most common reason patients come to the hospital. It affects every part of the body. It is present throughout life, never really goes away, and it varies from person to person and time to time. And there's really no test, no lab to date that can really help explain what pain is and what the experience of pain is for some patient. And there's no way to objectively measure pain besides the 0 to 10 scale that we're all very familiar with. And to try to better understand it, we did a study a while back. It was part of the PASI study where we asked patients to talk about their pain and let physicians and researchers know how often they were in pain. And we saw that the majority of patients heard well over half of the time. So pretty much in a day, more than half of the day, these patients will spend in pain. And about 1/3 of patients reported pain pretty much every day at all times. So this leads to seeing that for patients with sickle cell disease, pain is somewhat like an iceberg, where doctors and clinicians only see the tip, but the reality of what is below on this not seen by clinicians is really what the patient experiences every day of their life. And we can see that here, where although people see, the little bit, that snapshot of a picture of pain for patients with sickle cell disease, there is so much that help emphasize what that experience is like for patients with sickle cell disease. They have aching pain, they have burning pain, there's some anxiety in there, there's dull pain, and all of that makes their pain perception and their pain expression be consistently different than what a clinician or a provider would expect based on the presentation of the patient in the clinic at the time. And this is what makes pain a very personal experience for patients that have sickle cell disease. So one might ask, why is pain in sickle cell disease not like cancer pain? Because pain, for most people, is expected to just be pain. And the pain, or the type of pain that has been studied the most, is cancer pain because of the allocation of research for cancer disease. But the treatment of pain in sickle cell disease is not exactly the same, because the pain that happens for patients with sickle cell disease derives from the flow and the type of blood oxygenation that these patients receive. And that is one of the reasons why pain is so unpredictable for patients that have sickle cell disease, and which leads to clinicians always questioning the veracity of the pain that is reported by patients with sickle cell disease. So these are some of the pointers as to why sickle cell pain is different from cancer pain. There's low blood and oxygen delivery to tissues or organs of the body systems, like Dr. Pardo mentioned earlier. The pain in patients with sickle cell disease comes and goes very often, and it happens over and over. There's a pain level today, there's a pain level tomorrow. It happens continuously. And it's often very unpredictable. Pain for patients with sickle cell disease also happens throughout life. Sometimes for some conditions, patients will only experience pain while they have said condition, and when the condition is gone, there's no more pain experience. This is not true for patients that have sickle cell disease, given that this is a genetic disorder that is going to be with them for the majority of their life unless they get some form of treatment that will be talked about it on today. They get to experience pain for their entire life. And pain for patients with sickle cell disease is often questioned by providers. There are very few signs and symptoms about pain for patients with sickle cell disease, because as you might imagine, if I show up in the emergency room and I have a broken foot or a big gash on my hand, I'm bleeding, there's a clear expression, or there's a clear image being seen of why I may be in pain. But for patients with sickle cell disease, all the damage is done internally. So someone that is looking at a patient may never really see the manifestation of what is causing the pain for the patients. And therefore, since one can't see it, they are often misunderstood and not trusted when they report a certain level of pain. And pain for patients with sickle cell disease lead to very frequent emergency visit, which is not often the case for cancer pain because they get adequate treatment for their pain. And as one may expect, this also leads to poor medical care. Also, why is sickle cell pain not like pain in other disease? For very similar reason, as we talked about cancer pain, sickle cell disease pain is very different. You know, there are psychological consequences. A lot of people have built stigma around sickle cell disease, assuming or thinking that patients with sickle cell disease are always almost considered to be drug seekers because they misrepresent how much pain they're in. They want to get that higher amount of opioid being prescribed to them. Therefore, it leads to a lack of belief between the patient and the provider, and that leads to social consequences where patients start to try to get pain treatment for their condition in a non-clinical setting, which is not always good, and we can see how that can lead to a downward spiral. In this section, we'll talk a little bit about vaso-occlusive crisis. And vaso-occlusive crisis is essentially the phenomenon that leads to pain in patients with sickle cell disease. And for patients that are healthy, most of them have normal round red blood cell, almost like an orange. It's very easy to flow through vessels. There are no issues. But when a vaso-occlusive crisis occurs, that changes the scenario for a patient with sickle cell disease, which switches the normally round orange red blood cell to somewhat of a crescent, almost banana-shaped cell. And one may say, when or how or why does a vaso-occlusive crisis happen? But this happens in the microcirculation when sickle cell-shaped blood cells obstruct the vessels that lead to poor oxygenation delivery to the tissues, which in turn leads to pain. And this happens because of a phenomenon called polymerization. And what that is essentially when a combination of very, very small molecules bind together to create a chain-like formation that essentially bends the normal red blood cell into a crescent-shaped red blood cell. And once you have that, the flow of the blood in the tissue cannot be as smooth as though it would have been if it was a normally round red blood cell. And I have a small illustration to show. For example, we have, say this is a patient's red blood cell. These are normal red blood cells. You put in the normal red blood cell to flow. Let's see. You will see the normal red blood cells flows very easily in the patient's tissues or the patient vessels. There are no troubles. It's very simple flow. But then you take and you introduce a sickle-shaped blood cell. What does that do? It can't go anywhere. And the blockage that this causes allows for no oxygen or very little oxygen delivery to the tissue, and that is what essentially is a vaso-occlusive crisis, and this leads to pain. There's a slide here that illustrates it also a bit more, because besides just the changing of the shape of the red blood cell, there's a lot of chemical reactions going on into the organ that make everything be sticky, and sticky cells essentially can't move through the vessels. So you have occluded blood vessels, you have stickiness that goes, and all that just causes like a log jam in the patient's blood vessels, the artery or the veins, and all that reduces the amount of oxygen that is delivered to the tissue, which in turn leads to pain in very end organs, and sometimes organ damage and death. So what is the typical pain response for patients with sickle cell? For patients with sickle cell disease, the brain looks really different compared to patients that don't have sickle cell disease. All the accumulated damage to the brain that have ensued from when they were really young to when they get in the middle age and later age lead to a lot of manifestations that are yet to be evaluated. So essentially, the more these patients are in pain, the more they have vaso-occlusive crisis, the more they are end organ damage, notably like the brain, which create hypersensitivity to pain. And there are not enough studies that are laid out there to really understand the impact that has. And when a patient has sickle cell disease and they don't get the proper oxygen delivery to their brain, they have this leads to brain damage, which also reduces connectivity into brain tissue. And that poor connectivity leads to one can say reduced cognition, whether it's fluid cognition that is executive function, whether it's cognition about how the pain is perceived or how the pain is represented. All these accumulation essentially lead to very poor response and increased sensitivity for patients with sickle cell disease. And there's really no simple way to address the issue. There's no simple way to cure this. Patients end up hurting more. Typical medication don't help them down the road, and they really just remain in pain most of the time. In this section, we'll talk a little bit about the impact of sickle cell pain and vaso-occlusive crisis. So for sickle cell crisis are very, very expensive. Leads to a high use of emergency rooms, really high hospitalization rate. And it's estimated to cost about $2.5 billion per year for caring for patients with sickle cell disease. And as one can expect, the higher the number of crises, the higher the vaso-occlusive crisis, the more one can expect to be able to predict mortality in patients with sickle cell disease. And even research has shown this. For patients that have 1 to 3 crises per year, it reduces their life expectancy quite a bit. And this was further emphasized by a study where we looked at the impact of sickle cell crisis and sickle cell disease on essentially work productivity. And we saw that increased frequency of vaso-occlusive crisis for patients led to increased likelihood of the fact that these patients will be absent at work, decreased productivity, and decreased activities for patients with sickle cell disease. So sickle cell disease just is somewhat of a downward spiral for patients. The more they're sick, the less likely they are able to be productive into society. This also shows essentially what the study highlighted. Looking at the population, a sample size, I believe we have 100 and so patients. The majority of them were not employed or were employed for a little bit of time, and a lot of them were almost always out of work because of sickle cell disease. This shows a map that is a result from a research study about where patients with sickle cell disease experience the most pain. And for these patients, the majority of the pain was seen in their backs, their legs, and their thighs. And this leads to understanding how this could affect somebody's productivity, quality of life, and their performance. Because if you're always in pain in your back, in your legs, you're not going to be likely to be very active, to move a lot, to have the time and the ability to perform some of the physical tasks that may allow someone that is healthier to have a higher quality of life. So therefore, pain with sickle cell disease leads to a decreased quality of life. The impact of vaso-occlusive crisis also in children and adults with sickle cell disease. As we talked earlier, the more crisis we have, the more low blood flow delivery we have in end organs, the higher the likelihood of being socially castrated, essentially, of being really sleepy or getting very poor sleep, of being in pain, or of having very low cognitive functioning or reduced cognitive functioning, and all these compound on each other and lead to very poor quality of life and functioning for adults and patients with sickle cell disease. We did a study where we compared the quality of life for patients with sickle cell disease to that of those that have other types of chronic disease, such as asthma, cystic fibrosis, dialysis because of kidney disease. And the scale that was used was the SF-36, and we saw that consistently patients with sickle cell disease scored lower than other patients with other chronic disease in every single category, just showing the impact of sickle cell disease on quality of life. And as we talked about earlier, sickle cell disease and vaso-occlusive crisis can have a very high psychological impact on for patients. And on a study that was done, we saw that patients with sickle cell disease, 28 to 30% of them have a high expression of depression. A lot of them have anxiety. They tend to abuse alcohol a lot. And the majority, if not all of them, have some form of stress. And all of this leads to them almost always catastrophizing, or one may say exaggerating the amount of pain that they're in, or any other experience that they are having, or they tend to believe that whatever experience might be mild for a patient without sickle cell disease is a lot more catastrophic than what it actually is. And this leads to developing poor coping and poor self-efficacy skills. And we talked about this already, where we saw that the higher the higher the frequency of vaso-occlusive crisis, the poorer the participation and productivity was for patients with sickle cell disease. So we can see that sickle cell disease is a vicious cycle of pain. You know, the more pain we're in, the more anxious and the more anxiety and depression we have, which leads to more stress and poor sleep, which leads to fatigue, which in turn just results in more pain for patients with sickle cell disease. And we can see how this all just goes back and forth, and it turns out that because of this, we can say that pain is its own disease. So in summary, we talked about vaso-occlusive crisis being the hallmark of sickle cell disease, talked about how sickle cell disease starts and the changing the shape of the blood cells that lead to crisis and poor oxygenation. And we talked about sickle cell disease-related pain. See if anyone has any question. I'm happy to answer. All right, this seems to be a question. It says, can you speak on chronic pain and opioid-induced hyperalgia? Hyperalgic? Hyperalgic. Okay, so chronic pain and opioid-induced hyperalgia. Chronic pain, it's essentially a state where a patient is in continuous pain, whether the pain is on a 2 level every day, and there's no essential treatment that can actually make the pain go from a 2 level to a 0 level. And because of that, patients have to be on something called opioid maintenance, where they have to take a little bit of opioids every day to just allow them to be able to function on a daily basis. And that continuous intake of opioids often leads to patients building somewhat of a tolerance. And that tolerance, it's what can lead to opioid hyperalgia, where because of the high amount of opioids that is taken on a continuous basis, there's a low likelihood of patients being able to tolerate a certain amount of other opioids, which will essentially lead to opioid hyperalgia. There's another question that says, has the use of methadone changed the pain treatment modalities? I don't do pharmacy, therefore I am not exactly sure how the use of methadone has changed the modality. However, we've seen that patients respond to different treatments differently, essentially. So I'm sure that in some way, shape, or form, the use of methadone has changed modalities for some patients, but I don't think that it's an universal response for every single patient. And then we have another question where we see, have you had any experience with SCD patients experiencing amplified musculoskeletal pain syndrome? If so, do we have effective treatment for this? And how do you distinguish between amplified musculoskeletal pain syndrome and sickle cell pain? I have not yet experienced or seen a patient that has amplified musculoskeletal pain syndrome in the research that I have been doing. But I'm sure that if there are patients that have this syndrome in the clinic, Dr. Smith or Dr. Cecil will talk about it during their presentation. When patient told seek pain management, what does that involve? In our clinic, it typically revolves around getting the right pain plan in place and the right pain treatment plan also in place. And I say pain plan and pain treatment plan because in our clinic, we have a plan in place for how opioids and medication are to be distributed to the patient when they show up in the emergency room and when they also show up in the hospital for hospitalization. And there is another plan in place that involves patients navigators, a behavioral health team that help the patient understand how to approach or how to help better deal with their pain on a daily basis with a non-opioid approach. And to somewhat better understand this, there's a particular research project that I'm doing where we're scanning patients' brains, looking at how the blood flow impacts their cognitive levels, the sensitivity levels, and the firing of their brain signal. So what we're getting brain MRIs on patients, looking at cerebral blood flow, getting fMRI also to look at brain-blood connectivity and brain connectivities. We're also then giving these patients some cognitive testing and some fMRI-oriented tasks. We also ask them to answer a survey about their pain experience, essentially pain perception and self-reported pain. And we hope that by looking at this, we'll see the impact of blood flow and brain connectivity and what that does to cognitive function and pain processing. And why do I say that this is important? Is because when you look at patients that have sickle cell disease compared to patients that don't have sickle cell disease, research has already established that these patients with sickle cell disease have a higher blood flow rate that goes to their brain. The blood flowing that fast doesn't allow for enough time for the red blood cell to let go of oxygen in the brain, which in turn should turn for patients that don't have sickle cell disease into a healthy brain, normal brain functioning, and normal processing. But when you have sickle cell disease and blood flow is going that fast and you don't have the oxygen that is being delivered, you get to have almost like a not enough functioning in your brain and not enough firing in your brain, the connections are not being made. And when the connections are not being made, there's not enough signaling for the patients to process information properly. And that is what we think somewhat impacts the patient's cognition and the patient's processing level about their cognitive levels, about how their pain is perceived, and about how they report said pain. But I will ask Dr. Smith to come here and talk a little bit about this, because this is an area that he's very familiar with and an area of expertise for him. Right.
The questions that we've been getting, hello, I'm Wally Smith. The questions that we've been getting about pain are some of the toughest questions that one could ever answer related to sickle cell disease. We have given you a very good, basic introduction to what we know about pain and sickle cell disease, the hard facts. We're now about to venture into hypotheses. The hypotheses include those about pain getting better or worse with treatment, opioids. You got a question about that? Actually, you got two.
Two questions about it.
And then you got a question about central pain and chronic pain.
Chronic pain,
The kinds of chronic pain.
Hyperplasia.
All of that.
Yeah.
So here you go. And Daniel and I said we were going to revise this talk next year.
Yeah.
So that all the hypotheses can be included. We do not want you to walk away thinking that this is fact, because we're at the forefront of research, Daniel and others around the country, the National Institutes of Health, are at the forefront of research in trying to understand better pain and sickle cell disease. So you're asking good questions. We're going to give you hypotheses about answers. So pain in sickle cell disease begins as nociceptive pain. That means it's in response to the vaso-occlusion. That was the very basic things that Daniel showed you. And it begins in children as a simple phenomenon. You have vaso-occlusion, you have pain. The vaso-occlusion goes away, the pain goes away. Everybody's happy, the brain is happy. But imagine that happening over and over and over again over the years. And this is where Daniel's research comes in. Daniel's taking pictures of the brain that show not just acute changes due to pain, and we assume it's nociceptive pain.
Nociceptive,
That is, vaso-occlusion caused it. There's oxygen deprivation. And then a pain signal goes up to the brain as a result. All right, that's the first kind of pain. But there's another kind of pain that goes along with chronic pain, where the brain actually thinks there's nociception going on, but it's not.
It's not.
So phantom limb pain is a good example of that. You cut somebody's leg off and they still have leg pain where there is no leg. That's the brain doing what has been rehearsed to do. That is to think that there's pain going on. The signal is actually starting at the brain. So chronic pain in sickle cell disease and in many other diseases may actually start at the brain. How crazy is that?
It is wild.
And that means that our opioids and all the other things that we're doing to try to treat that pain are barking up the wrong tree.
The very wrong tree.
Treating the wrong thing. We are just beginning to get our hands around that fact. Somebody talked about opioid-induced hyperalgesia. Well, can you imagine what opioids might do? Do you think they might trick the brain, reset the brain, so that it fires in the way that I just said? Possible. And so we have in laboratory animals, we can show, if you give somebody opioids long enough, you reset the brain, you trick it into thinking, oh, There's pain going on. There's pain going on when there's no opioids are there.
Yeah.
That's a very simple but profound beginning of hypothesis about where we are in understanding pain in sickle cell disease. So if you put it all together, an individual with sickle cell disease could have nociceptive pain from vaso-occlusion.
Yeah.
They could have nociceptive pain from an organ,
From an organ damage.
like your leg, your hip, your ankle.
Yeah.
You see the wound, it causes pain.
It causes pain.
That's nociceptive pain too. They could have neuropathic pain from brain damage.
Yeah.
You've damaged the nerves, you've damaged some part of your nervous system, and that is causing trouble. Or they could have, here's a word, nociplastic or central pain, where the brain thinks there's pain going on, but there may not even be a pain signal. The pain signal starts here.
Yeah.
The patient experiences it as pain in an extremity. They experience it as pain somewhere other than where the pain
Where the
signal
pain
starts.
is coming from, yeah.
And so we're excited because the work that you're doing, and many others like you, begins to show how some of these signals are actually working. And we're just tipping the iceberg when we talk about Daniel's work. If we had time, we could talk about psychophysical testing, and
Yeah.
we could talk about
QST.
QST, we could talk
quantitative
about
testing.
surveys, we could talk about
fMRI.
okay, so somebody says, well, what kind of pain is that? It was nociplastic, nociplastic. That's a new term. People just coined that term. The old term was central pain or brain plasticity pain. What else?
Central pain, because brain is very plastic, very pliable, likely to change depending on the inputs that it receives.
Yeah.
Yeah.
So how do you treat this kind of pain? Hypothetically. Hypothetically, you would try to untrick the brain. You would try to get the brain reset. How do you reset the brain? One way would be to try something called mindfulness meditation.
Meditation.
There's actually changes in the brain that occur when people do mindfulness or meditation over long periods of time, and people believe that you could trick the brain into doing that. Another thing would be to try to teach people to cope with the brain pain and recognize it's not a crisis.
Yeah.
Cognitive behavioral therapy, acceptance and commitment therapy, physical therapy,
That's a big one.
acupuncture to cause stimulation to oppose the central
Signal
signal.
that is essential.
These are all areas where we're trying, and maybe even drugs like gabapentin and Lyrica. These are all things we're trying, but we have no good data yet to explain all of this pain. So that's a little bit of an answer, deeper than perhaps people were expecting, to the questions that you were getting about pain.
Pain, hyperplasia.